That's great. I know we're a little bit over
time, yeah.
Maybe we can take one or two questions. George.
Can I ask a naive question?
Oh, those are the best kind.
This is not my field, but tell me about how you deal with tolerance and whether tolerance is a varying factor across these individuals and whether it relates at all to outcome.
Right. I think you came in a little late, and I started off by talking about how buprenorphine relative to other opiate analgesics. No, I can quickly answer the question. It produces less receptor internalization, endocytosis, and less mu receptor phosphorylation. And so those tend to be correlated with, if you have greater internalization and phosphorylation, that's correlated with greater tolerance. So buprenorphine is low on that scale, like morphine, incidentally, but unlike other standard opiate analgesics. So we don't see much tolerance to buprenorphine, at least for the treatment of opioid use disorder. Yeah?
I was just curious, is there any age-dependent data? Like, does it seem to work better in younger versus older people who've abused heroin for 2 years versus 20?
That's a great question. Well, let's put it, so age is confounded with duration of use, inherently, right?
Right.
And so we've actually done a lot of analyses just of heroin abusers, not necessarily on buprenorphine. But in general, the longer somebody's been at it, the more refractory to treatment they can be, especially, well, part of it depends on how many prior treatment episodes they've attempted. Actually, the more you try, the better you are at succeeding in subsequent quits. So it's almost like a practice effect. Okay? So you actually increase, every time you attempt to quit, and this is true across drugs of abuse, you tend to increase the odds that you'll eventually succeed. Of course, again, that's confounded with age and duration of use, right? So sorting all of that out is difficult. I can't readily think of good scientific data to answer your question, but it's an important question. I mean, you know, because we have a lot of, I mean, there's this old lore about people aging out of their drug use habits, right? And I'm not sure we have great experimental tests of that. I think they're more observational kinds of data, right? It's the kind of thing that would be great for an animal study, you know. But I think, you know, we know that there's, you know, that the neurobiology changes, you know, as you age, and so maybe you reduce your susceptibility to the reinforcing effects of drugs, maybe, and or you become more sensitive to the effects of certain medications. And it's an important question. I mean, especially as we see people, you know, living longer, and we're trying to get more of them into treatment. We need to really have good answers to that. Yeah.
What about gender susceptibility? And also, you know, we are at the state level with respect to buprenorphine use during pregnancy and then postpartum. So many times at the state level for Michigan Medicaid, I know this is a loaded question.
That's okay.
They want to stop as soon as the patient delivers. You know, I'm a good friend of Carl Christensen's, you know, chair of the P&T committee for Medicaid, and we are trying to tell the folks on the committee and the policymakers, you know, it's sort of like high blood pressure, diabetes, you need to work at this as a chronic condition, and they're saying, well, change them over to methadone. What are your comments about methadone versus buprenorphine in light of this and gender differences?
I think, to answer your first question about gender differences, I don't think there's a lot of solid data showing differential gender responsiveness to buprenorphine in clinical trials. The second question, you know, focused more on women, especially pregnant women. Yes. My colleague, Andre Jones, did the landmark clinical trials, the MOTHER study, which is an international study actually, that directly compared buprenorphine versus methadone, and basically buprenorphine won. It's better because you have less neonatal abstinence. May have to do with the affinity and the slow washout effect, so that you don't have to medicate infants as much when they're in the NICU. my general philosophy of life is if it ain't broke, don't fix it. So if somebody's already on buprenorphine, don't discontinue care. This, like you say, it's a chronic condition to be managed. You're doing a disservice from a policy standpoint if you're disrupting a level of care that the clinician and the patient mutually judge to be effective. So if somebody prefers to be on methadone or they're continuing to use other opioids on top of buprenorphine, clearly buprenorphine by definition is not effective, and so maybe going to a full agonist to the extent that the dose is safe, well tolerated, that may be the way to go. But I wouldn't backpedal.
Okay,
I mean, it's a harm reduction type of approach.
good, thank you.
Sure, great.
Mark,
Thank you.
Thank you
Thank you.
very much.
Okay.
Thank you. Thank you.
And I'm happy to stay around if anyone wants to.